everyone, I'm Sang-Chul Lim, today's moderator. I am happy to be with you again by Dentium Live Surgery and Follow-up. As always, today's live surgery will be performed by Dr. Chung. The topic for today is narrow reach simple implantation using pin guide system. You will be able to learn the periodontally compromised socket management and Dentium's pin guide added Flapless surgery. Let's take a look at today's case. About the patient information, 64 years female patient. Her chief complaint was, I want to get a new front tooth, implant supported tooth. Past dental history was tooth extraction due to tooth extrusion 1 year, 3 months ago. Bone grafting was performed when extracting these teeth. It means ARP was performed at the time. Past medical history, breast cancer, stage 2. We can see the panoramic view before the surgery. Number 11 and number 21 area, we can see clear some grafted bone masses on the socket area. After 4 months, I think this mass is already transforming the partially newly forming bone. However, we cannot clear see these histologic formulas because we don't have any biopsy. About cone-beam CT view, you can see 11 area, 3.2 millimeter width, 21, 3.0 millimeter. A very narrow, reduced reach width. It means actually already a periodontally compromised situation. In occlusal view, in the intraoral view, we can see the already extracted site on upper anterior tooth, number 11 and 21. So, narrowed ridge and the reduced vertical height already. So, actually this sort of ridge type is very difficult to overcome to make proper the standard position. However, today we're going to see how can we manage easily this sort of reduced anterior ridge, narrowed and reduced vertically. So Dr. Chung gave us a key and the proper and simpler the answer to solve this problem. What about the surgery plan? We will have a 2 implant installation, a bright tissue level, diameter 3.0, length will be 11 millimeter. So also today specific the tools will be introduced. That means that name pin guide system, Dentium pin guide system. It is very nice devices for Flapless implantation especially. Right implant system tissue levels already introduced you for a long time, as many times as a narrow but strong style cause of external connection, beveled external connection. That is the key and unique and characteristic of bright tissue level, right? Once more, beveled external connection. Please keep in mind about this bright TL. 20 degrees beveled. These areas contact to the abutment internal surface, so gave us a strong connection even though the external connection type. So concave neck portion to make a better emergence profile and gingival profile. The neck portion is always the same, 3.81 finger diameter connection. That is unique and the favor to use this bright TL Okay, let's move to the pin guide system. Let me introduce this pin guide system a little bit detail. First of all, this pin guide developed for the flapless surgery. When we have a flapless surgery, we want to know the bone geography underneath soft tissues. According to the using cone beam CT or some another devices gave us a good information about this bone geometry. However, this direct pin gave us a tactile sense. Also, during the tactile sense, gave us more accurate and intrinsic bone geometry information underneath these soft tissues, the target area. So, mapping alveolar bone and optimized for flapless surgery and excellent performance in narrow reach cases. That is the characteristic and favored using pin guide system of Dentium company. Pin guide system have two different type. First one simple, another one is full pin guide kit. Full pin guide kit have lots of devices more than simple. Simple devices have a 3 bendable guide and also probe blade holder. It means the probe, like working as a probe, and the pin, the 20 degrees bendable pin. And another side, pin guide full kit. You can see the straight pin and 15 and 25 degrees. Different types of 3 different types of pins are available from this kit. It means during the surgery, flapless surgery, the angled pin gave us a benefit, to promote the easier assessment to the flapless surgery osteotomy site. Okay, let's move to the similar case 1. Similar case given to you for more comprehensive understanding. This similar case 1 is lower anterior narrow reach area, 32 and 42 area. As you can see, very narrow, thin ridge. Actually, these areas need for prosthetic final prosthesis will be seated between canine to canine, right? However, ridge is so narrow. So, first, a blade marker. This one is working as a probe. So, a blade marker insert actually the mucogingival junction area, from the mucogingival junction area and the keratinized gingival area. So insert blade marker, contact to bone surface, and after that we're gonna tagging this pin guide between bone surface and underneath periosteum, right? So this pin stabilized, fixed between periosteum and the alveolar bone surface. So during this inserting procedure, we're going to see, we can understand, we can recognize bone geography underneath these soft tissues, where some defect or some areas have some depression or some narrow inclining areas around there. All of these informations gave us to proper installation, even though this sort of narrow reach. And after pin guide inserting, we can measure the proper osteotomy site, and starting with Lindemann drill, the guided drill, and final drill. So we can see clear understanding. This pin guide already inserted between these narrow ridges. One is inserted the labial portion, another was inserted the lingual portion. So between the pins means the ridge width, right? So we can understand about 2 millimeters. Sometimes this area is maybe 3-4 millimeters width of bone. We can the imaging estimate, right? This one, right? And after that, we can proper positioning. We're gonna proper positioning for initial drilling for using the Lindemann drill. And after that, the centered picture shown us a proper the initial drilled the paralleling pin inserted this osteotomy site with just after the initial drilling. So the evaluate and the cross-checking, the pass and the distance and angulation, all the three-dimensional pass is okay. We can go next step. Next step means inserting implant fixture. So 2.5, 3.5, 3.0, that doesn't matter. We can go these implant fixtures installed. The Bright TL is good matching partner for using this pin guide system. Let's see this picture. Bright TL 2.5 diameter and 11 millimeter was inserted this narrow ridge, and after that the thrust was used for checking ISV value. This ISV is very similar, almost the similar equivalent, the score of ISQ. So 82 means very high initial stability, right? So I think this sort of above 80, maybe over 70 means scanning and the simultaneous prosthetic procedures will be done. It doesn't matter. Okay, and pin guide system added implant inserted on lower anterior narrow ridge. We can see the panoramic view, very nice, well done, installed on number 32 and 42 area. So according to this cone-beam CT, the very nice and accurate inserted between the cancellous bone, right? The lingual plate, cortical bone, and also the labial cortical plate between both of these cortical plate. Exactly the accurate inserted this the cancellous bone between two of these cortical bone plate. So this picture 2.5 diameter Bright TL was inserted very accurate. So even though without any the computer assisted system, just only tactile sense using pin guide system, and before starting surgery we may review the panoramic view and the cone-beam CT. However, this pin guide system and the Bright TL implant fixture is a good combination, good partner to make a flapless surgery. Okay, after that, the scanning using the intraoral scan, and we can get the scan image here. This scan image was used for making a temporarization. So using the CAD design for temporary, and the provisional restoration was delivered to our clinic just one day after, or sometimes we can make just after the surgery, right? The same day provisional restoration delivered will be possible, or the next day of surgery will be available this kind of provisional restoration using iOS. And however, I want to say I just want the checking, the pointing the photo. You can see some of resin bonding area between number 32 and 33. The canine and the temporary lateral incisor, both of lateral incisor connect with the natural canine teeth for the stabilization, right? So when we have temporization, the immediate temporization or the early loading at the protocol, this resin bonded system, the resin bonding to neighbor natural teeth style is helpful to get the stabilizing, the better stabilization. And checking sheet taking, and the BTS, this BTS ordinarily used for final restoration, making final restoration. And as I mentioned before, this BTS system, the BTS, the scan is more accurate compared to intraoral scan, especially long span or free-end style. Just the single is almost the same, doesn't matter. The 3-unit bridge, I think they're almost the same. However, the 4-unit bridge, longer, the curved or free-ended style, these areas, BTS tray taking, impression taking, and the scanning is better, the accurate and better than iOS scanning. Okay, for the final restoration, the CAD, the program used and designed, and the milling, sintering, glazing procedures was done, and finally we can get this final prosthesis from our laboratory, so delivered to our patient mouse. Screw retained type, and I think SCRP or screw retained type is available at this sort of prosthetic procedure. Cause of angulation is good for this screw retained or SCRP type. However, sometimes the little bit labial version implant inserting cases don't worry, it doesn't matter that we can make a cemented type, the final restoration. In this case, we have just only 3 incisors inserted between this empty space. So the final restoration, the final panoramic view is here. The very nice, well done, and the marginal, the bone, the stable, and the angulation, all the 3-dimensional scales looks good. Okay, let's move to similar case 2. This case a little bit unique. The bright TL, the ordinary used for narrow reach, right? So many persons think about this bright TL as a tool for overcoming the narrow reach. However, this bright TL, we can use this bright TL system for the regular reach or a little bit the wider reach, like a premolar area. Sometimes we're going to use this bright TL on the molar area, even though the slightly the smaller diameter than the standard bone level fixture diameter. It means this bright TL is stronger than the bone level implant system cause of its unique and the characteristic, the connection system, the beveled, 20-degree beveled external connection. That is a very strong point for understanding this bright system. Anyway, number 14 and 15, the premolar area. So extraction. So as you can see, this area is not so much rich width. About cone beam CT, this area is not so much the full not so small, however not so enough. So in this kind of cases, the best approach technique is Flapless. So the bright TL is one of a good choice for overcoming this area. Not fully healed site, cause of extraction site is not fully soft tissue healing. It means just 1 month after extraction always looks like this intraoral view. Maybe over 2 months after extraction, this slightly depression's gone away. So a little bit flat and thicker than before, right? So according to these intraoral photos, we can guess about between 1 month after extraction, between 1 and 2 months between after extraction. So, as I mentioned before, first, marking, user braid marker. It means working as a probe. So, where? About around the mucogingival junction area, where between the periosteum and the surface of the bone, right? And braid marker probing the bone surface, and after that, the blade inserted after using this blade marker. So, blade was inserted. Sometimes straight blade inhibit the access to the osteotomy drill. So at this time point, actually we're going to use the angled pin inserted like 15 degrees or sometimes 25 degrees, right? Let's see, guess. The ridges looks like here. So straight pin, buccal straight pin inserted like here, and another lingual portion inserted pin looks like here. So pins crossing the top portion of the ridge. So sometimes this kind of situation inhibit the proper accessing the initial drill. So this sort of case, actually 15-degree curvature inserted pin is better to promoting the access. However, this case, the straight pin was inserted. Drilling, parallel pin insertion, checking the path and angulation and mesiodistal distance and buccolingual angulation. All of three-dimensional position was good, and go to the next step, the final drill for the installed implant fixture. So 3.5 diameter, 9 millimeter bright TL was inserted. Another one is 7 millimeter. 9, 7 doesn't matter. The current trend nowadays, the minimalism concept. So 7 millimeter is enough. Developed macro design of implant fixture. So 7 millimeter that gave us enough initial stability and also the osseointegration, even though the molar and premolar area. So this 7 millimeter gave us a lot of benefits when we have sinus areas surgery, right? So 7 millimeter, preventing the touching the sinus floor. So we skip the sinus surgery when you use 7 millimeter, this sinus area. And after that, you're using checking ISV and inserted foam, the Flapless surgery. So simpler and faster healing. Very nice. Lots of the benefits for using this the pin guide and bright TL for the Flapless surgery. So faster healing, maybe, and 1 week, 2 weeks is enough to have the temporization, even though the final restoration. So Cone-beam CT shown us about this information. As I mentioned before, this 15 area, the sinus flowers touching the tip of the implant fixture. So the bicortical fixation concept was applied on this implantation. Number 14 is regular implantation. Okay, the healing 4 weeks. It means 1 month later, the starting with the final the procedure to make a final restoration. IOS scanning, the temporary CAD, design, and temporary crown first. And the looks like final. However, this one is PMMA temporary crown. So insert it into our patient mouth and get the temporization period for making gingival molding or some the functional evaluation. Good. And healing 3 months, enough evaluation period. And then the moving to final restoration here. Then the same as before, the IOS for temporization, the BTS for final restoration. Very simple. Very good and accurate. Final restoration design here, and the zirconia, milling, coloring, sintering, glazing. The final restorations delivered to our patient mouth. Looks good. Yeah, very nice. Good gingival texture. Let's see final prosthetics panoramic view. The very nice and marginal bone and looks good, and the emergence profile was good, and all of the situations looks good. Okay, the follow-up 6 months later. Yeah, the gingival, the position, color, textures are very nice, and the marginal contour is good. I think good maintaining these areas, implant supported prosthesis number 14 and 15. Okay, follow-up 1 year, 1 year follow-up panoramic view. As you can see, the marginal bone areas are stable there, stay there, and in other situations looks good. Okay, let's move to today's surgery. Today's surgery have already done something more. It means after extraction, and the ARP, the socket preservation procedures already done here. And today, Dr. Chung will have just installation with a Flapless surgery concept using pin guide system. So before today, as you know, when the patient visit our clinic, upper anterior incisor, the periodontally compromised, so gingival and alveolar bone, the reduced vertically, and also the horizontally the reduced. So this kind of case is very complex to make a good performance. However, let's see. First of all, the upper anterior teeth should be extracted, and after that, we're going to do something more. So that is ARP, alveolar ridge preservation. So extraction, irrigation, and all the granulation tissues removed. And when we have this the step, we have to check the labial bone plate and lingual, the palatal bone plate. The palatal bone plate, the ordinary thicker than labial, so this the palatal bone plate, the always or the ordinarily still survive there. However, the labial bone is totally different, very thin, and the bundle bone is located the top portion of CJ area, as you know. So extraction means disappear the bundle bone, the top portion of labial bone. So thin biotype or thin the buccal bone plate area, maybe after extraction, so gone away after 3 months. So before there, we're going to do something more. So ARP, socket preservation, or some another procedure like a GBR procedure using the regular standard membrane with a particular bone. However, today, before the surgery, the extraction, the thorough granulation tissues and irrigation. After that, using osteogenocollagen for the socket preservation. So, I think the labial, the gingival texture, I think not rigid style. So it means the gone away already labial bone. So, can you remember the cone beam CT view? Due to cone beam CT view, the labial bones already reduced the bone volumes already resorptions happen. So simpler ways here, like the collagen bone, like osteogenocollagen, inserted into the socket area after thorough debridement of all the granulation tissues should be removed and the cream, and then put the bone graft material inserted, and then suture, and that's it. So wait 4 months, we may have something more for another step. Okay, so extraction and CAD temporary for during the healing stages. Patient want to have some the temporization. So this CAD designed to make a temporary the anterior. So the Maryland bridge type, the temporary bridge was delivered and bonded just after extraction. And during the whole these healing stages, this temporary provisional restoration was inserted in our patient mouth 1 month, and after 3 months, taking the cone beam CT, these socket areas, white bone particles shown us about a little bit transforming the newly forming bone. However, that is just a scheme, right? This is not exactly histological result because we don't have any histologic specimen. However, the ordinary 4 months is enough to make another step. Okay, so just before the panoramic view is here, the white spot, the socket area, is a good scheme for us to make implant installation. Okay, finally we measured 3.2 and 3.0, the ridge widths. So intraoral view is here. This sort of case actually Flapless is best option, right? Without flap reflection, just Flapless surgery is the best option. So I think today's surgery will be successful, and also the very interesting interesting introduction to using the pin guide system of Dentium company newly developed. Surgery plan is here. The implantation, number 11 and 21 area, bright tissue level, 3.0 diameter, and length will be 9 or 11. However, depend on the drilling. Dr. Chung is final choosing the proper length of fixture. Flapless implantation using pin guide system, as I mentioned before. Okay, let's move to today's surgery. Checking using the probe. The center portion is not immertured, as you know, as you can see, right? So this sort of case, the flapless surgery is a better option, the better choice. So Dr. Chung is decided flapless surgery and the checking, the inserting point using the spin marker, the braid marker, on about around the CJ area, and this pin, now its pin is inserted. The always pin should be located between periosteum and bone surface, right? So 15 degrees pin inserted here. The right side straight, left side 15 degrees inserted. Okay, so he's going to change a straight pin instead of 15. If you're fixing this pin improperly, for example, between just the soft tissues or upper periosteum areas between the connective tissue area, maybe this pin is impossible to fixing. So during the surgery, pin is movable like this one. So it is not exact information, give us information about the bone geometry, right? So always the pin placed between periosteum and bone. So this pin is not movable anymore during the surgery. So always indicate the proper bone geometry and width. The labial portion, we have a 2 pin inserted already, and after that, Dr. Chung starting the initial drill for the proper positioning. Okay, today he didn't insert the palatal, the portions pin insertion, just only 2 labial portion inserted pins are seen. The 2.0, first Lindemann already used for proper positioning. So you can see some of particle, the number 11 area, you can see a little bit the particle of socket area. It means the osteon genobone graft material is not fully integrated newly forming bone. However, the volume was maintained and the strength of this immature bone is enough to have initial stability when we have implant insertion. So that is not critical point. Here, fixture was inserted. 3.0 diameter, 11 millimeter. The RPM is faster than the normal recommended by a company. The company always recommended about 25 or 30 RPM. However, Dr. Chung is faster RPM than this recommended. So I think the 50 RPM is always used for installed implant fixation. Okay, remove plastic cap. This plastic cap working for protecting the screw hole, right? Screw thread inside of fixture. That's it. Removing plastic cap, the protecting cap, and connect with this scan abutment. This abutment working as a scanning jig, and the second one working as a healing abutment. Sometimes the longer one we can use for the temporary abutment, right? Yeah. The nickname is a 3-in-1 abutment. Anyway, another implant inserted. Can you see the final drill? No, right? So Dr. Chung is undersized drilled. So 3.0 diameter fixtures. So just he want to go 2.5 drill diameter. So undersized drill is a necessary part, the very important part to get the proper initial stability when we get the implant installation on the grafted site, right? The grafted site is softer, immature compared to the host bone. Even though 4 months later and 6 months later, GBR procedure, this grafted area is not too hard. So to always try to undersize drill. Okay, checking ISP. Yeah, he told about the score. It's a 72. As I mentioned before, the 70 over 70, 72 is enough score to make a temporarization. Yeah, surgery is finished. Very well done. Okay, we will have a 10-minute break, and after that, we're going to have a Q&A session. Thank you for watching. Okay, thank you for waiting. Let's see post-op intraoral view. We can see the after surgery cause of due to Flapless surgery. No bleeding anymore, no suture. It's just the scan abutment inserted this implant installed area. We can see the panoramic view and the cone beam CT. So this cone beam CT shown us about the big benefit, big favor using this pin guide when you have Flapless surgery. Very accurate insertion of these two implant fixtures, right? The proper positioning between exactly the cancellous bone area between the labial cortical plate and the palatal plate, right? 3.0 diameter fixtures, the absolutely perfect seated between the cortical plate into the cancellous bone area. So that is very important factor to get the long-term, the successful follow-up. Okay, after 1 week, the 1 week after surgery, the very nice, the gingival schemes and gingival textures and colors, all the situations perfect. So we're gonna do starting the prosthetic procedure. So as I mentioned before, the intraoral scanning for the temporarization. So the design on CAD and make temporarization using the abutment. This abutment, the stock abutment for the bright TR system, the abutment inserted connect with the already installed implant fixture, and the top of this abutment seated by this PMMA temporary. The screw hole located in the labial and incisal area, it doesn't matter, cause of this one is provisional, and after provisional period we're going to make a final lastration. Then maybe we're going to make a final lastration, the cemented type. So during this temporization period, we're going to check a gingival line and interdental papilla and all of this, the soft tissue contour and situation. And after that, we're going to do the final lastration procedure. Okay, the question is here, while using a pin guide, how should GBL be performed if it is required? A very good question, very excellent question. Thank you for the asking. During the Flapless surgery, the ordinary question is here. If the bone grafting are needed case, or if I want to have a GBL procedure or some bone grafting when you have a Flapless surgery, how can I perform this situation? So the ordinary case for the Flapless surgery, not necessary to have a GBL procedure with a flap open. If you want to have a bone grafting, the first implant insertion for proper position, accurate positioning using this pin guide system. So between the cancellous, into the cancellous bone, between labial cortical and the palatal cortical, right? So the proper diameter, 3.0, 2.5, as you know, and insert perfect the same, exactly the correct position. And after that, the exposure surfaces of fixture case or the labial bone plate is so thin case. You know, the long-term follow-up success, the labial bone plate area need minimum 2 millimeter from the outer surface of the fixture and then outer surface of bone, right? That is a regular rule, 2 millimeter minimum. However, the under 1 millimeter case, actually after the final procedure during the functioning, gingival will be a little bit recessed, and then the labial bone resolved, especially the marginal bone area. So we need bone grafting or GBL procedure. How can I perform this procedure? The ordinary case, I prefer to use the pouch technique. The pouch or tunneling, make a vertical incision from the one side and another side and make some tunnel. Sometimes we make a tunnel or just only make a pouch. Pouch means to make a space between bone surface and the periosteum using the instrument and the detachment periosteum from the bone surface. We can make enough room for the bone grafting. Then after that, put the bone grafting into the pouch or the tunnel. So at this time point, what is the most adequate bone graft material? So the collagen bone is much better than the particulated bone. Why? Collagen bone is easy to mold and easy to handle, and also easy to holding the proper positioning, right? So I always try to use collagen bone like osteon genocollagen, sometimes osteon 3 collagen. Osteon 3 collagen is alloplastic graft material, so it is better then better to maintain the tissue volume and bone volume. However, if you want to have a little bit more newly forming bone, you want to get the more newly forming bone, so the genocollagen is better than the alloplastic. Anyway, like this, the collagenated bone inserted, the already making the space using the pouch technique or tunneling, and suture, that's it. However, if you want more the fixation after this procedure, you can use a membrane, which is GBR membrane, the top portion of this graft material is covered with collagen membrane, right? So using the collagen membrane, the tunneling technique is better than pouch because of insert membrane, GBR membrane at this area, and then to put it out, and then another tunnel, the entrance, and then holding suture, or sometimes using the pin, and there are many the ways, method to fix the membrane and the underneath the bone grafting materials. Nowadays, instead of a regular GBR membrane, the collagen membrane, I prefer to use collagen graft 2. Collagen graft 2 is thicker, make a thicker the collagen matrix. It is not cross-linked. However, higher the soft tissue friendly the graft material. So collagenated bone, osteogenocollagen, and the collagen graft 2 is better, the best combination for making GBR and the bone grafting procedure. When we have, especially when we have Flapless surgery, right? So just vertical incision, make a tunnel or the pouch and making a space, and put bone graft materials if possible. Collagen bone is better. And after that, if you want more something to do, the collagen membrane applied between the bone grafting and the upper soft tissues, or instead of this collagen membrane, I prefer to use, as I mentioned before, the collagen graft 2 is better to get the better volume maintaining and the faster tissue integrating. Okay, so please try to like this the procedure when you have a Flapless surgery using bright tissue level and collagen graft 2 and collagen bone like osteogenocollagen as best combination to make the thin, rich, the problem, the key factor to use the overcoming thin, rich problem case, right? Okay, thank you for watching today, and see you next time. We will have April 18th, another live surgeries will be performed at 7 o'clock. And the very interesting the theme that will be spreading, an interesting theme of the live surgery that will be broadcasting. Okay, thank you. Bye.